All right, welcome to part 1 of chapter 15. In this section, we're going to talk about, we'll go over a little bit of the airway anatomy. We're not going to get in great detail about it. We're just going to do a quick review so we can identify some landmarks that will be discussed in later sections of this chapter, as well as some physiology. And we're going to talk, we'll get pretty in depth into acid-base balance just so we can bring that information back to the surface and make sure that everybody has a good understanding of what's going on in that area as well. Our bottom right-hand corner down here on your screen, you'll notice that it's got a little box up down there. Just ignore that. Our computers on campus are all doing an update, and there's nothing that I can do about it. So it's going to kind of be there, but it shouldn't get in our way. Just try not to let it distract you. Okay? One of the main things that we do, and one of the first parts of our assessments that we do is establish and maintain a good airway, making sure that thing's patent, so that we can have effective oxygenation and ventilation because the body requires a constant supply of oxygen in order to be able to function. If we interrupt this supply of oxygen, bad things begin to happen relatively quickly because the body has very little reserves of oxygen in place to kind of make up for a loss or a deficit of oxygen. The respiratory system that we're going to talk about in this entire chapter brings in the oxygen and eliminates the carbon dioxide through that gas exchange process. Without getting too far down in the weeds about the gas exchange process and Boyle's law and Henry's law and all those types of laws that some of you have already heard about from me before, just realize that this happens off of the gas pressures, and that's based upon the amounts of either one of those will create greater pressures, and it'll affect the gradient and the direction of which way those gases will move across a membrane. I've included some of those videos of how that process works under the physiology section of those videos and articles. So feel free to refer back to those if you need a little bit of a refresher on how that gas exchange process works. But realize that our vital organs are going to begin to fail relatively quickly when we get into an oxygen deficit environment. So it's very, very important that we manage the respiratory system or manage breathing problems relatively quickly in order to have the best outcomes for our patient. Because a failure to manage the airway issues properly is the leading cause of preventable death, or is a major cause of preventable death in the pre-hospital setting, and that pre-hospital setting is us. So we need to make sure that we understand the importance of early detection of these airway problems, and we have rapid intervention to those. And then we can do a continuous reassessment of any patient that has any sort of airway or breathing related issues. This appropriate management of an airway patient includes the following, but it's not really limited to just these things, but it needs to, at minimum, include these. Open and maintain a patent airway. So if their airway is not open, we need to open it and we need to maintain it. If their airway is already open, we need to make sure that that airway is maintained open. If you have a conscious patient when you start out and your patient becomes unconscious because of hypoxia, realize that once they become unconscious, they're probably no longer able to maintain the airway themselves. So now you may have a respiratory patient or a respiratory-related patient that now was able to control their airway, but now is unable to control their airway, and you still have the original problem that you started out with, but you still have to maintain, now you have to maintain an airway, adds a different wrinkle to it. So recognize, also you need to recognize and treat any airway-related obstructions, adequately assess the ventilatory and oxygenation status of the patient, administer oxygen where needed, and provide ventilatory assistance where needed. In many areas of paramedicine, I often tell students to show a little bit of restraint. Don't get in a hurry to give this drug. Just because the algorithm or your protocol says if you've got a patient with this, give them this. Don't be really quick to jump to give them those kinds of things. Set back, assess, make sure that it's the most appropriate and right thing to do. But the one situation that I'll tell you that I do encourage you very much to be aggressive is airway related issues, because these things can go south on us really, really quickly. And then we've got a really big mess on our hands, because those are the kind of situations where you don't want to wait on, you want to act. You want to jump in there, provide assistance, and get that taken care of quickly, because they'll go downhill in a hurry. All right, a little bit of a review, just so we know some anatomical landmarks when those things are discussed later, so everybody's on the same page of what's being talked about, so we're not going, what is that thing that they're talking about? So upper airway, when we're talking about the upper airway, we're talking about everything above the vocal cords. So everything above the Adam's apple is considered the upper airway. The pharynx, of course, extends from the nose and mouth to the esophagus. So that's that portion inside the nose and mouth. We have the oral pharynx and the nasal pharynx, and the laryngopharynx. Of course, you know, the tongue is a great potential for an obstruction. It's actually the #1 cause of airway obstruction. So the tongue has to be managed as well. And it's something we have to watch out for. Of course, here's a picture, nothing new, nothing earth-shattering here. But here's a picture of that, the upper airway, right? The larynx marks the upper and where the upper airway ends and the lower airway begins. In that area, we have a thyroid cartilage, and it's formed by these two plates that form the laryngeal prominence, or the Adam's apple. So right there in that area, we've got that thyroid cartilage and all that stuff that's going on. There are some things that we need to be aware of when we look at the larynx itself, because there's some procedures that we do that happen in this area. Okay, so we've got the cricoid cartilage that's down here. We can see it down here at the, down here at the bottom down here. I'll bring my pencil up so I can draw on it. Got the cricoid cartilage down here. Got the thyroid cartilage up here. What you need to realize is running right along the side of this, kind of here and kind of here, down this way, are thyroid arteries. And basically we've got, the reason why this is called the thyroid cartilage and these are called the thyroid arteries is we've got these thyroids that kind of set alongside here like this. They're fed with not a big artery, but there's a sizable enough artery there that we need to be aware of it, that it exists there. Now, of course, not everybody's anatomy is the same. Somebody's artery may be a little more further this way and some may be a little further this way. And we need to be aware of that, because this cricoid membrane right here, this spot right here, that's where we do a cric. So if we do a surgical cric or a needle cric, we're going to do that right in here. Most of the time we do a surgical cric, which means we're going to take a scalpel and we're going to make a cut in here and then we're going to poke through that membrane. What oftentimes we see an inexperienced person do is when they take that scalpel, they want to cut across this way, like that, and then open the skin back and poke through that membrane. Well, the problem is if you cut this way, you're very likely to hit those thyroid arteries. And I've actually seen a physician do that. So we recommend when we make this cut that you make the cut up and down or perpendicular instead of laterally. So that way you greatly reduce the possibility of nicking those arteries, because if you nick those arteries, you nick one of those arteries, and now you're going to have a mess on your hands, especially if the patient, when you cut through that membrane, if the patient exhales or blows a bunch of air out through the new opening that you created, you're going to spray blood everywhere, which is exactly what the physician did that I witnessed do this particular procedure on a patient. So knowing this anatomy is important, and knowing, structurally where things kind of lie, so that when we're doing some procedures, we're not making some bad mistakes or some costly mistakes. Okay, so of course we got that cricoid cartilage, this is what I just talked about, and then we've got the cricothyroid membrane. It's just a ligament that connects the two, and this is where we do that that surgical cric that we call a cricothyrotomy, or we just shorten it up to cric. A surgical crike requires the use of a scalpel, and then there's a needle crike where it usually comes in a little kit and it's got a needle and all that stuff that kind of pokes down in there. You'll learn all about that stuff later. The glottis is the space between the vocal cords. So when you hear it referred to as, you're going to insert the tube through the glottis, that's what they're talking about. They're talking about that space in there. All right. And of course, this up here is the epiglottis. Just some landmarks that you're going to need to be familiar with when you go in there and you start learning how to intubate a patient. When you're placing tubes and that kind of stuff, and you're putting your laryngoscope and getting everything kind of in the right place. We can't really see it, but here's the base of the tongue right here, and between the epiglottis and the base of the tongue is the vallecula, and that's where we're going to, you can't really see it, it's kind of back behind that because this epiglottis kind of pokes out, almost like a little tongue, it kind of pokes out there. Behind that and the base of that is the vallecula. If you're using a curved blade or a Macintosh blade, that's where you're going to set the tip of your blade, is in there in that vallecula, and then you're going to manipulate the tongue. If you're using a straight blade or a Miller, you just kind of sweep the tongue to one side. But you'll learn all that stuff in class, but landmark-wise, when they're talking about this procedure, these are the structures that they're referring to, and it's important for you to kind of know what those are, so you know what you're looking at when you get in there. Of course, beyond the glottis, when we go through the glottic opening, or right there at the glottic opening, just past the glottic opening is the trachea. Realize that it's not necessarily a straight tube. It's got a little bit of a curve to it. It doesn't just go straight down. It's got a little slant. Of course, that's the trachea is a little bit lower down. It's below the Adam's apple. Oftentimes, the trachea and the larynx get a little bit confused or mixed up, but the trachea is just down below that. If you have somebody, a patient that has a long-term indwelling breathing tube or a trach tube, that's where that's at. It's in the tube below that. So it's down below the vocal cords is where they place that, and they take them into surgery and do a surgical procedure, and they work their magic in there, and they come out and they've got this tube that can be interchanged. It can be replaced. So, okay. We need to realize, of course, you should realize, I don't know why I say we need to realize, I know you guys already know, that the respiratory and cardiovascular systems work together. They bring oxygen as well as other nutrients to the cells, and they remove waste products through the use of blood and that kind of thing. So, but there is a correlation between the respiratory and the cardiovascular systems that is very important, and one is absolutely vital to the other. It's vital for the lungs to do the ventilation. That is the physical act of moving air in and out of the lungs. It happens in two phases, of course, inhalation phase and exhalation phase. What I try to remember is, or I always try to think of, is the inhalation phase is when the rib cage and the diaphragm create a negative pressure environment inside of the lungs and air rushes in. And exhalation is the opposite of that, is when those two, the ribs relax and the diaphragm relax and they go back to the normal position. They create positive pressure that pushes air out. That's the breathing process. Breathing process is a very active process. It requires intact muscles. So we have to have intact nerves go into the muscles in order for the ventilation process to actually work. Now, we can have ventilation and still have inadequate breathing. We can have those muscles working like the dickens and not getting anywhere. So that's why we must ensure that there's adequate ventilation. So just the mere fact that somebody's chest is moving out and their diaphragm's moving down does not necessarily mean that air is actually changing places. So we must make sure that there's air changing places, and we do that by listening, and that will give us an indication of how efficiently or how effectively the lungs are working, because we can hear the air moving in and out. So we put our stethoscope on there and we listen to see how well the air is moving in and out. and we assess their ventilation. Oxygenation is the process of loading oxygen molecules onto the hemoglobin in the bloodstream. Now, what this is going to require, it's going to require adequate ventilations, meaning adequate air movement in and out of the lungs, but it's also going to require an adequate flow of blood moving past the capillaries of the lungs in order for there to be enough hemoglobin to load the oxygen molecules onto. Also, if there's any obstruction or if there's any obstacle between the air and the alveoli, or between the air and the capillaries of the alveoli, if there's fluid in there, or if there's anything like that that's creating an additional barrier, it's going to limit the amount of oxygen that moves from the air environment into the fluid environment of the bloodstream. So there's a lot of variables and a lot of factors that can affect oxygen moving into the bloodstream regardless of how much air is moving in and out of the lungs. So we can move air in and out of the lungs, doesn't necessarily mean that it's translating into oxygen moving onto the hemoglobin. So the process of actually exchanging oxygen and carbon dioxide, is called respiration. So ventilation is just moving air. Respiration is actually exchanging oxygen and carbon dioxide. So we have mechanical respiration or external respiration, whichever way you want to call it. External respiration is the exchange of oxygen and CO2 between the alveoli and the pulmonary capillaries located, inside the lungs. Internally, the cellular respiration is the exchange of oxygen and CO2 between the circulation, the bloodstream, and the cells. So there's two types of respirations that go on, and both of them are equally as important. So if we don't have the mechanics of moving air in and out of the lungs through ventilation, we're going to create a mismatch. We're going to create a lack of oxygen. Things aren't going to work right. We're going to have a buildup of CO2 because we're not getting rid of that either. Or if we have the ventilation right, but something is interfering with the exchange process within the lungs, whether it's a fluid buildup or a pump problem that's not getting enough blood moving past there, then we're going to have a problem there. But if we have good ventilations and good respirations at the external level or at the lung level, meaning we're getting things on and off of the cells, but for some reason internally it's not offloading or working properly there, then we're going to have a problem as well. So there's several elements to this. There's several things that need to work in order for respirations or the onload of oxygen and the offload of CO2 to work properly. Okay? Any one of those go south on us, we've got a problem. Okay? I would recommend, once again, because of the talk, kind of the respiration stuff kind of falls in with gas exchange because it's a big part of it. There's some gas exchange articles and videos under the physiology section of helpful videos and articles. So feel free to look at those. Most of them are at a level that's not really difficult to understand. It's not like, it's somebody at Princeton or Harvard, talking about that process. So it is a little easier. Some of the videos, I'll be honest with you, are not real entertaining. They're kind of boring, and some of them actually cover some of that information you may already know pretty well. So you kind of got to wade through some stuff you already know to get to some really good golden nuggets. For those of you that are like me, that really feel like they need to understand a process very well in order to kind of grasp it, I encourage you to look at what's listed underneath physiology of how this breathing process works, and hopefully gain enough information that you're able to kind of get that. Feel free, though, if you do still have questions about that, to send me an email. Of course, you can send it to me and Curtis if you want, but if you send it to both of us, I'll jump in and try to answer those questions. So Curtis won't have to, because this is kind of my area where I specialize in a little bit. So now let's talk about the pathophysiology of respiration. So any disruption of pulmonary ventilation, oxygenation, or the respiratory process will have immediate effects. And we need to be able to recognize those things immediately. Sometimes it's a little easier than others with some of those things. Sometimes it's much more difficult and it's less obvious. Sometimes our patients have a long storied history of some respiratory issue, or they smoked for 40 years, and it's pretty easy for us to kind of figure out what's going on with them and why. Doesn't mean that we can fix it. Other things, we kind of have a patient present to us and we're scratching our head trying to figure out what's causing this. Well, realize it's far less important to know the cause initially than it is to just treat what you've got in front of you and correct what's going on. Once we make the corrections, then we can start to go, what's causing this, and is there something that I can do to fix it? With these patients, we need to make sure we get an immediate fix. Obviously, we got a patient that's in respiratory distress. They're hypoxic, their lips are blue and all that kind of stuff. The first thing that we're going to do is throw some oxygen on them, if their airway's patent and all that, I get it. Throw some oxygen on them and then start to go, okay, well, we got some oxygen going on them. Start to find out some things that's going on, and maybe it's a breathing treatment, or maybe it's some other issue, but that's what we're going to do. We need to make sure that we're treating that. Remember, I said I want you to be aggressive with airways. Now, that doesn't mean I want you to go out and intubate every patient that you come across. What that means is don't take any airway issue for granted. And this is going to be even more important with the older a patient is or the younger a patient is. It becomes a whole lot more detrimental to that patient because they don't respond well. But anyway, be aggressive with airway. Like I've said before, every single cell needs a constant supply of oxygen in order to survive. It has to have oxygen in order to do the processes that are essential to that cell's not only function, but survival. Of course, oxygen is just one part of the equation, right? Realize that we also need glucose as well, but with a respiratory patient, glucose is not usually the problem. The problem is oxygen. We need to make sure we get that. So one of the other side of that coin is we've talked about the lungs, and if the lungs aren't working right, and if there's fluid in them, or they're constricted, or the air passages are constricted, or that kind of thing, that's going to affect the ability to be able to onload oxygen or offload CO2. The other side of that is if there's not a good enough blood flow, there's got to be enough of a blood flow circulating past and through those capillaries of the alveoli in order for that gas exchange to take place. So we have to have good circulation going on as well. That's another reason why whenever we have a patient that's in respiratory distress, one of the physiological reactions to hypoxia is the body automatically increases the heart rate and increases the blood pressure. They want to make sure, the body wants to make sure that, hey, the problem isn't the heart and isn't the blood vessels. If it is, we're going to take care of that. We're going to push as much blood as we possibly can past those capillaries in the lungs, so that more oxygen can be taken on, more CO2 can go away. The problem is if the lungs are working great but the heart's not, now all of a sudden we got a problem with the flow. There's not enough blood going past those tissues in the lungs in order to effectively bring on oxygen and get rid of CO2. So when this happens, regardless of the cause, whenever we don't have enough oxygen to the tissues, we call it hypoxia. Now that's when they're not receiving enough. It's hypoxia. That doesn't mean that it's without, which would be anoxia, is without oxygen. Hypoxia means they're not getting enough. So This will have a varying degree of signs and symptoms depending on the severity of the hypoxia. Early signs may just simply be restlessness, irritability, some tachycardia, maybe some anxiety. Later signs, we start to see some significant mental status change. The pulse begins to weaken. We start to see cyanosis and those types of things. I know it seems kind of counterintuitive for there to be a decrease in pulse in late stages, but remember, there's been a lot happen between the early and the late stages, and now we're starting to get to the point where things are starting to shut down. Obviously, if we are becoming more and more hypoxic, there's less oxygen for the heart muscle to work, so it's going to begin to slow down and it's going to become less efficient. It's going to pump less blood through the lungs, and as a result, we're going to get more and more hypoxic. That basically is a kind of a catch-22 that the body will get caught in as hypoxia begins to worsen and it remains untreated, or sometimes even when we're treating it, they start to go down that, start to make that death spiral, and it's very difficult, if not impossible, for us to stop. It seems odd that we would have trouble in today's day and age treating somebody with asthma, but I have had more than one, probably 3 or 4, young 20-something asthma patients crash on me. And you wouldn't think that would be the case because it's like we've got all of these things that we can do for them, but sometimes it's still not enough. People die of asthma in this country every day. Asthma can be a very serious disease for some people. So realize that sometimes all our best efforts don't do anything, and that's why I say treat airways very aggressively. Or manage them very aggressively. Once again, that doesn't mean intubate everybody. It just means be aggressive with it. I've talked about this already, but there is a ventilation perfusion ratio that must be maintained in order for there to be oxygen to the tissues. Obviously, if the heart's not pumping effectively, then we're not going to move blood effectively. We're not going to take oxygen on effectively, and we're not going to be able to push that oxygen to the tissues effectively. And vice versa, we won't be able to get rid of the CO2. So not having a good pump messes everything up. We don't get good gas exchange. We wind up with more CO2 stuck in the bloodstream. We see gas exchange or the hypoxia, oxygen-related issues are similar in many ways to a patient with a lung problem as with a heart problem. The effects are essentially the same on the body, but the cause is different. For instance, a congestive heart failure patient where the left side of their heart's not functioning well, but the right side is functioning wonderfully. The right side's pumping plenty of blood through the lungs, and so much so that it begins to back up, and now we get fluids backing up in the lungs, which hampers the gas exchange process. Also, the left side of the heart's not working very well, so it's not moving the blood well through the tissues and back to the heart. So that problem results in tissue hypoxia, much like hypoxia for any other cause. But the symptoms we see, the hypoxia symptoms are somewhat similar, but remember also we're going to see different symptoms that are based on the cause of the problem. Meaning, if we have an asthma patient that's hypoxic, we're going to see hypoxia signs and symptoms, some mental issues and that kind of thing, and respiratory patterns. We'll see similarly with a CHF patient, but a CHF patient's going to have fluid in the lungs where an asthma patient has constricted bronchioles. The causes are different, we see similar things, and our treatments are often different. So it's important for us to recognize that. Sometimes students that are first getting out there, or not students, but paramedics that first get out in the field, they listen to lung sounds and their inexperience of listening to lung sounds, they hear something that sounds like, hey, that sounds wet in there, I need to give them Lasix, because they got fluid in their lungs, and they give them Lasix, and it turns out it's pneumonia. This is why it's very, very important to don't jump to conclusions. If you've got a patient that's in respiratory distress, that's hypoxic, put them on oxygen, do a good assessment to where that you know for certain what it is that's going on with them, and not just jumping to conclusions without having all of your facts in order. Giving Lasix to a pneumonia patient can be fatal. So that's why it's very, very important that we do our due diligence with our assessments. The last section that you just finished, assessments, I'm going to tell you, paramedics live and die by their assessments. What I mean by that is paramedics don't go to court or go to court because of their assessments. They don't make mistakes if they do a very, very thorough assessment. So begin your treatments early, start taking care of things early when it comes to airway, giving them oxygen, doing those kinds of things, keeping the airway open and that kind of stuff, and then start looking for the cause of that. That's what you can start to correct, okay? Some other factors that affect ventilation. Some of these factors are intrinsic, some of them are extrinsic, meaning some of them are inside the body, some of them are outside the body. Some intrinsic factors such as infection, allergic reactions, unresponsiveness, these are all internal to the body. So those are some factors. They may or may not directly affect the respiratory system, but they are factors that are inside of the body and not outside. Extrinsic factors such as trauma, foreign body airway obstructions, those types of things are all extrinsic factors. Hypoventilation, what that causes, it results in a buildup of carbon dioxide. And hyperventilation is an excessive elimination of carbon dioxide. The way that they look at hyper and hypoventilation is on the carbon dioxide side. The reason for that is the mechanism that causes us to breathe, the trigger, the thermostat. You know, you got a thermostat in your house and you set the temperature at a certain temperature, and when it goes, you know, if it's the heater, for instance, when the temperature goes below the set point of the thermostat, the heater kicks on and warms things up. When the temperature inside the room gets to the set point of the thermostat, it shuts off. Well, carbon dioxide is that trigger for the respiratory system. It's the thermostat of the respiratory system, so to speak. The body measures the level of carbon dioxide in the bloodstream through the chemoreceptors inside the body. It measures the amount of carbon dioxide in the body and sets the rate of respirations and even the speed at which the heart's beating, how hard the heart's beating, those types of things, to adjust accordingly if there's too much or too little carbon dioxide in the body. You would think it'd be oxygen that is the measurement, but it's not. It's CO2. CO2 is actually pretty dangerous in the body, so the body wants to regulate that. Oxygen actually is too. A lot of people don't realize that oxygen can actually be toxic. That's why oxygen is transported in the bloodstream on the hemoglobin of red blood cells, and red blood cells contain antioxidants, meaning they contain things that will keep oxygen from oxidizing what it comes in contact with. So oxygen, it can be a free radical if it's released. So oxygen has to be regulated pretty well, as does CO2. CO2 is regulated pretty well too, but there is some CO2 that floats free in the bloodstream. Most of it is actually transported in the form of bicarbonate in the bloodstream. So the body uses carbon dioxide as the trigger for the respiratory rate, depth, rate, that kind of stuff. It's what triggers it. And hyperventilation affect that. The normal range for that, for CO2 in the body is 35 to 45 when we measure it in blood gases. Now, the interesting thing about that is someone that is a COPD patient or asthma patient, emphysema, asthma, bronchitis, those kinds of things. If they're long-term on those, what happens with them is their body eventually kind of resets out of necessity, because they typically will have a higher than normal CO2 level over the course of time, and eventually the body will reset the thermostat to reflect that higher level. The problem is if with that patient, if we get aggressive, overly aggressive with them, and give them a ton of oxygen over a long period of time, we'll eventually push their CO2 level down to the point to where the thermostat will just literally turn off, and they'll stop breathing because it says, whoa, it is way off the charts in range here, so we're just going to shut down. Problem is it shuts down, but it's very difficult with those patients to get it to turn back on. That's the difficulty with them. And typically I recommend, if you can avoid it. Now, I'm not saying don't do it. Please don't misunderstand what I'm telling you. Typically, I recommend intubating a COPD, emphysema, bronchitis, or asthma patient kind of as a last resort, because those people wind up in the ICU on a ventilator for days trying to get weaned off of that. And there's some of them that just say, I don't ever want to be intubated again because I don't want to go through that again. They'd rather die. So I'm not saying don't intubate them. What I'm saying is make sure that you have no alternative. It's the only way. It's the next best alternative. And I'll be honest with you, I have intubated many COPD patients, and that was the whole time knowing and trying to show a little bit of restraint in doing that. But you'll do it after you've been doing this for a little while. You'll start to recognize those patients that need it right now, that need to be intubated right now, and you won't even try anything else. But consider that what's going on with them or what's going to happen long term prior to just intubating them. If you can manage it another way, try that. But I'll be honest with you, you'll probably wind up intubating most of them anyway if they're that bad. So just some food for thought. So, all right, so there's some external factors. Of course, problems with the ambient air. Altitude will affect pressure. Now, it doesn't affect the percentage of oxygen. Standing here at sea level, we'll say at zero feet, right at sea level, there is 14.7 pounds per square inch of pressure being placed on your body. And this pressure comes from all of the molecules in the air. Now, if you take all of the molecules that's in the air here and add up all the molecules that are in the air all the way above us, the weight of those molecules pushing down from just their normal weight, gravity pushing them down or pulling them down, that weight equates to 14.7 pounds of pressure on every square inch of our body and everything around us. Now, if we go up to the top of Pikes Peak, which I think is somewhere around 14,000 feet, that pressure is going to drop from 14.7 pounds per square inch to somewhere under 10 pounds per square inch. Now, the percentage of oxygen, it still has the same 21% oxygen as the air here. The percent of oxygen doesn't change, but the number of molecules above 14,000 feet is a lot less, so the weight of those molecules pushing down is less. Think of it this way: when you go under the water, when you dive under the water, the further you get under the water, the more of the weight of the water above you begins to affect your body. It's the same thing when it comes to air molecules in our environment. So when we go up to higher altitudes, it's not the fact that there's a lower percentage, percentage ratio, meaning of all the molecules in a given mixture of air at 14,000 feet, 21% of them is going to be oxygen, but there's less molecules there, if that makes any sense, because there's just not as many molecules of oxygen at 14,000 feet as there is at sea level. That affects how much oxygen we can take into our body. The relative percentage overall doesn't change, but the number of molecules that are present does. If you really want to try to understand that more in depth, there is an article on that in that, with all those help videos and articles on physiology that tries to explain that a little bit better. So also there can be an environmental situation where there's a deficit of oxygen, whether that's some industrial environment or a fire or any number of things can affect that. Also, there can be other chemicals and things within the air that create a problem. For instance, carbon monoxide is going to create a problem because it's going to occupy the hemoglobin of red blood cells and not let oxygen on. So those things can affect that, and those are all external factors that affect oxygenation and respiration. Remember, oxygen, when we talk, remember, here's the thing. When you're taking a test, here's what I want you to remember. Respiration is different than ventilation. Ventilation is mechanical. Respiration is the actual movement of gases. Okay? It's important to remember that because that can get you mixed up on a test. It can mix you up a little bit. All right? And then, of course, there's some internal factors that may reduce the surface area for that gas exchange to take place, such as some non-functioning alveoli from, lung cancer or just lung damage or that kind of thing. Fluid in the lungs from near drownings or congestive heart failure or any number of things, or aspiration. Is going to create a barrier that gas has to pass through. It's going to make it more difficult for that process to work. And of course, there's some environmental conditions and hazards that will cause an internal change to occur, some chemicals and those kind of things. It's going to cause damage to those tissues inside of there. That's going to cause it'll result in an internal problem due to an external exposure. Okay? All right? Let's see, of course, hypoglycemia will affect our ability to use oxygen effectively in that Krebs cycle. Remember, we need glucose for that to happen. Infection just completely messes up the metabolism inside the body, and it really dramatically increases the needs that the body has. So especially, this becomes really problematic if you have somebody that's already frail, and they're kind of doing their best to hold their own at a normal day, and now they've got this infection going on that's disrupting things and increasing the needs. And of course, hormonal imbalances such as ketoacidosis and those types of things can cause problems as well. Okay? Circulatory compromise. If we don't have a good pump moving blood around, we're not going to move enough cells past the surfaces of the lungs in order for that gas exchange to occur. And it will also inhibit it at the tissue level, at the cellular level, from that occurring as well. Any heart condition that reduces blood flow to the tissues, blood loss, of course, bleeding and blood loss either from anemia or some kind of traumatic event. Anytime that we have shock, shock is going to affect how oxygen is delivered or how efficiently oxygen is delivered to the tissues. Any instance where we have poor perfusion is going to be a problem, and it's a circulatory problem. It doesn't necessarily have to be the pump. It could be the container that's causing the problem. But a circulatory problem is going to have very similar results. The interesting thing is when somebody dies because they bleed out all of their blood, what kills them is the lack of oxygen, not the loss of the blood. But the lack of oxygen is caused by the loss of the blood. The ultimate cause is the cells didn't have enough oxygen to survive because of the loss of blood. Okay? Hopefully that's making some sense. All right, acid-base balance. Guys, please try not to get mad at me because I like to talk about acid-base balance. So we're going to spend a little bit of time talking about acid-base balance. And so you guys have a really good understanding of what's going on with acid-base. And really what I'm going to focus on is not so much what causes the changes of acid and base and all that stuff. You're going to get some of that stuff later. But I'm going to talk more specifically about the scale. So when we talk about acid-base, we're talking about a measurement of pH, which is basically it's a measurement of the amount of hydrogen in the blood. And the way that they get this number is they draw blood, arterial blood. They do a blood gas, and it'll tell us the pH as well. So this pH, it's a numeric scale. The pH is a numeric scale. It's actually a logarithmic scale that's used to specify the acidity or alkalinity of an aqueous solution. Really wordy, right? So the pH scale basically tells us how acidic or how alkalinic a solution is. It's oftentimes, the scale is a negative of the logarithm to base 10 of the concentration of hydrogen ions. You guys are loving me now, right? You know, because now I'm bringing, you know how you guys, I hate to tell you this, but you know how you guys back in pharmacology, you learned some math, and most of that math was pretty basic math. We're going to talk a little bit about some things that are more algebraic in nature. Now, try not to panic. I'm not going to have you make you trying to solve for X and do all those kinds of things, but just want you to kind of see things from a little different perspective than what you maybe have seen them in the past. So it will add to your understanding of what's going on. Okay, so this pH scale is the inverse of a base 10 or a scientific notation for that particular, for hydrogen ions is what we're measuring. And I'm going to explain that. So bear with me. So a pH scale has a range of 1 to 14. You see some of them with 0, but a lot of them you see, most of them are 1 to 14. 1 being pure acid and 14 being pure alkaline. Why is that significant? Because, well, I'll tell you, because a pure acid is almost completely hydrogen. You know, so hydrochloric acid is like a 1. It's almost pure hydrogen, meaning when we put hydrochloric acid in water, it liberates all kinds of hydrogen, and it's just, I mean, an astronomical amount of hydrogen. And I'll show you what I mean here in just a little bit. 14 is pure alkaline. So if we put pure alkaline in water, it's actually going to take up hydrogen. That's the two differences on the scales. Now, what's interesting is this pH scale is measuring the amount of hydrogen in a solution, right? So if hydrochloric acid has the most hydrogen in it, there's this huge amount of hydrogen in it, why is it a 1 compared to the pure alkaline being a 14, which has no hydrogen in it? Doesn't make sense, does it? Well, that's what I'm going to try to explain. Also, you need to realize that a pH of 7 is completely neutral. Typically, tap water is neutral. And what I mean by that is, you know, if the tap water is healthy tap water, it's a pH of 7 is neutral, neither acidic nor basic. Normal human blood has a pH of about 7.35 to 7.45, or just slightly alkalinic. And I'll tell you, it doesn't take much getting out of, that's normal. It doesn't take much getting out of whack on either side of that for it to be not only detrimental, but quickly fatal. Never will you see a pH, you might see a pH that dips below 7, but typically that's going to be fatal for that person. And you'll never see a pH of 8, or if you do, it's always going to be someone that's headed for the morgue. You know, so this range, you know, very little, like, it's a very tight range, and very far outside of that, yes, you get acetic and basic, but it doesn't take much out of range for it to be fatal. So when we refer to pH in people, when we say they're acetic, right? We say, oh, they're acetic for whatever reason. That means that their pH is below 7.35, right? So if it's 7.31 in pH terms as far as humans, we consider that acetic, okay? Even though in the big scheme of things, it's actually closer to neutral. But realize that we call that acetic. So a number below 7.35 in blood pH is going to be acetic, and a number above 7.45 is going to be alkalytic, okay? But what most people find is odd is a number below 7.35 actually has more hydrogen ions than the 7.45, and how is that the number is getting bigger, but it has less hydrogen, and the number getting smaller has more hydrogen, but it's getting smaller. That's usually the confusion with that. So, sorry, went backwards. All right, so there's that scale. And this is kind of the question that I ask. So if a pH is measuring, the number of atoms, hydrogen atoms in a solution, and an acetic solution has more hydrogen atoms than an alkalotic solution, how is it that a pH of 3 contains more hydrogen ions than a pH of 11? How is that? Well, there is an explanation for that, and it's all math. It's because the pH scale is a logarithmic scale, and it actually reflects the inverse of a base 10 number, or a scientific notation of numbers. And we're going to take a closer look at that so you guys have a better understanding of that. So, hold your hat. So water has a pH of 7. It's considered neutral, and it contains, and here is that base 10 number, or scientific notation. This right here, the number of hydrogen molecules is measured in this number like this right here. That is a base 10 number, or scientific notation of a number. And if we take this number, and what this is, it's 10 times 100 to the negative 7 moles of hydrogen, or if we wrote it out as a standard, a standard number, it would be 0.000001. That's how much hydrogen is in that particular solution. It's neutral. Orange juice, on the other hand, has a pH of 4, and it contains 1 times 10 to the negative 4 moles of hydrogen, or 0.0001. Now, what I want you to look at is, look at how many zeros are in front of the 1. 1, 2, 3, 4, 5, 6 zeros in front of the 1. This is a very small number, right? This only has 3 zeros in front of it, and this is a bigger number, right? You guys seeing that? Because of the decimal place? Well, the way that this works is, it's because this scientific notation here and this negative right here, okay? So that negative right there means if we take a regular number, like in this case, the number is 1 right here, so this is the number that we're dealing with, right? So if we take number 1 and we've got it there, and a number 1, a regular number 1 is going to have a decimal place right here, right? Okay? So in order to represent this in normal standard terms, we would say negative 4. Negatives always go to the left, positives always go to the right. So we'd go 1, 2, 3, 4, put our decimal place, and add the zeros. Okay? So that's where that notation comes from. So actually, a pH of 7 measures like this in a standard or scientific notation, because this, remember, we're measuring hydrogen, right? And a neutral solution of 7 has less hydrogen molecules than orange juice does at a pH of 4. And if you look at the two numbers, obviously this number down here in the orange juice, this number here, is bigger than this number here. That's a very small number. And that's why, and this represents the number of hydrogen molecules. So there's more hydrogen molecules in this one than there is this one, okay? So that's where that's at. But what my problem was is I said, well, this number here is a positive number and this number here is a negative number. How does that work? Well, how is that? Well, actually, it's fairly complicated but fairly simple. pH is actually a measurement of the negative log of hydrogen. And so if we have a pH of 4, that is the negative log of 4 right here. So we see the scientific notation. Remember, orange juice had a pH of 4 right here, which is this, which gives us this. So we know that this is the scientific notation of hydrogen, and that's what we have to use. Another way that we can put it, we can get rid of this 1 down here, because 1 times 10 is still 10, right? So we can get rid of this 1, and we can show it like this, which will give us this number here, ultimately, in our pH. So to take another look at that, okay, so we know that a pH of 4 is this number here. We know that a pH of 4 is actually that many moles of hydrogen. And we got a pH of 4, which is this, or this, which equals that, which is what we just did on the last screen. The simplest conversion is to take the pH and place it in the base 10 form by adding the negative in front of the pH number and then putting it in this format. And then we can take that and convert it into a standard notation number. Okay? So, right here below that, if we got a pH of 9, we take and we plug that 9 in here, right there, and then we take our decimal point, we got a 1, and then we go 1, 2, 3, 4, 5, 6, 7, 8, 9, and this is what we come up with. So, a pH of 9 has a very low concentration or a low concentration of hydrogen, meaning it is an alkalotic solution, okay, because of it's such a low concentration. There's a little more into that than what that is, but I'm trying to put this in pretty simple terms. So let's try this, all right? Okay, right here. So convert this into pH. All right, so we've got this here, we got a 1, so this is 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, right there. So 11, if we move that to the negative 11, so that's 10, 1, oh geez, let me erase that, if I can figure out how. There it is. Sorry about that. So if we put it in scientific notation, so in order to convert that to pH, we need to put it in scientific notation, okay? All right, so we put it in scientific notation. Then we need to put it in parentheses, put negative log with 10 down there below it. Now, what we can do with this is we can eliminate this right here, because 10 times 1 is 10, so don't really need that there. And we can clean this up a little bit. Put that like that. Now the interesting thing is without getting way off into the weeds and talking about logarithms and how they're all put together, this right here, this will cancel out this, okay? So that will cancel out that. Now we're left with this and this. Remember, two negatives cancel out, and now we're just left with this right here, which is our pH. So when we convert this number to pH, we move it over here, and it gives us this 1 times 10 to the negative 11 scientific notation. Remember, we have to convert it to scientific notation, and then we can convert it using the logarithm formula, so to speak, for lack of better terms, into what the pH would be. Okay? All right. So if we have a pH of 2, now we want to convert the pH of 2 into standard notation. Okay? Now we need to do this backwards. All right? Rather than do that, we know that if we have a pH of 2, we have 1 times 10 to the negative 2, right? So if we got a pH of 2, we know it's this. Pretty easy to convert that to standard notation. We just do 1 decimal point 1 2. Ooh, I'm not sure how I did that, but there it is, just like that. That is 2 converted to scientific notation. Or we can just take the 2 and know we need to move the decimal place 2 points if you really just want to shortcut it, right? All right, so I encourage you to kind of play with some numbers like this on your own. Remember though, don't get confused by this number here. Oops, sorry. Come on. Don't get confused by this number here. Don't try to put 2 and then move your decimal place and do that. That'll mess you up. Remember, with the pH, if we start out with the pH, we're using a 1 here and moving the decimal place 2 places. All right. So if we start there with an 8, right? If our pH is 8 right here instead, that'll change things just a bit. So if this is an 8 that we've got, sorry, it's kind of hard to read that. Remember, we'll put a 1 down. Don't put an 8, put a 1, a normal 1, and put the decimal place right where it should be. 1, 2, 3, 4, 5, 6, 7, 8, all the way over here, and you can't see my numbers, it's already all gone. So basically, what we're going to have is, well, that's kind of weird how that did that on me. Basically, what we're going to have is we're going to have let me put it up here. Sorry. We'll have a 1, 2, 3, 4, 5, 6, 7. We'll have that. We'll have a 1 with 7 zeros in front of it, which is very alkalinic. Okay? All right. Anytime you have a 1 with less than 6 zeros in front of it, it's acidic. If it has more than 6 zeros in front of it, it's alkalinic. Why? Because a 1 with 1, 2, 3, 4, 5, 6 zeros, if we counted these, 1, 2, 3, 4, 5, 6, 7, is a pH of 7, which is what? It is neutral. Okay? So play with these numbers, practice these formulas a little bit, try to get a little bit familiar with them so you guys have a little better understanding of that. Okay? All right. That acid base relies on the amount of hydrogen in the body, and that hydrogen is a reflection of the presence of CO2 in the body. The more CO2 there is in the body, the lower the pH is going to be, and the more hydrogen atoms are going to be present in the body, the more acidic the body's going to become. The reason why that is how CO2 is dealt with within the body. It'll bond with water, with H2O, and when it bonds with water, it actually releases a hydrogen. In one of the two H's in H2O, it releases a hydrogen, and that creates more hydrogen in the bloodstream. It's one of the ways that it kind of does that. So when you have an excess of CO2 in the body, there's a lot of water in the body, right? So it's going to easily or readily bond with that water and create a free hydrogen. One of the first ways the body deals with that is through bicarbonate with H2CO3. I think that's what bicarbonate is. I can't remember if I'm wrong. I'm sorry. But that's it deals with the excess of CO2 that way is by trying to trap that CO2 into a molecule and creating a molecule of bicarbonate. So it'll take the CO2 with some water, and it'll try to grab that extra hydrogen and grab an extra molecule of oxygen, and it'll create H2CO3. Okay. The problem is if you're in an oxygen deficit environment, there's no extra oxygen molecules to be had, so it's not able to trap that. It's not able to utilize that to manage the excess hydrogen. And I know that's not completely accurate, and we'll talk about that hydrogen CO2 conversion stuff a little bit later when we get into pulmonology. I really wanted you to kind of start you off with having an understanding of acid-base, and then we'll talk about where that hydrogen comes from. But I want you to realize that there is a direct correlation between excesses of CO2 and excesses of hydrogen. So when somebody's not breathing or not breathing well and they're having a buildup of CO2, that results in a buildup of hydrogen as well. I'll clarify that later in later chapters. I don't want to throw any more at you as it relates to this in this lecture, but in later chapters we'll talk about how that carbonic and bicarbonate transition works in relation to oxygen and CO2 and all those factors that come into play. Okay, but for now, just realize excess CO2 translates into excess hydrogen, results in a lower pH or acedia, as you know, an acidic state. A lack of CO2 or a loss of CO2, however you want to do it, results in less hydrogen and greater alkalinity. So the inverse is true. Try to think of it that way. Also realize that the majority of CO2 is actually transported within the body in bicarbonate. Once again, that's something that we'll discuss in more detail in a later chapter. So the respiratory and renal systems help try to maintain a balance of this by getting rid of CO2. Or with the renal system, it actually helps to get rid of hydrogen ions, but that system is quite a bit slower to react in doing that. The respiratory system is the quickest to act because if it can blow off CO2, it can help balance out the equation of the excess hydrogen. That excess hydrogen can be taken up and dealt with. And reverse it can slow down to retain more CO2 if the body's more alkalinic in order to release or to free up more hydrogen to maintain that balance. And of course, excess acid in the body is basically expelled from the lungs in the form of carbon dioxide. Now, realize that we talked mainly about carbon dioxide in relation to the pH scale, but hydrogen in relation to the pH scale. But realize carbon dioxide plays a major role in the amount of hydrogen that's in the bloodstream. And the way that we can balance acidity in the body is through removal of carbon dioxide because of its how it interacts with other things, water and other things in the body that releases hydrogen. We get rid of the CO2, those things that CO2 normally interacts with go back to normal, and they take up that hydrogen, and it balances out the pH, gets it back in normal levels. Of course, if respiratory function is inhibited, we're going to have a buildup of CO2. It's going to cause acidosis because that buildup of CO2 is going to cause the CO2 to bond with other molecules in the body that release hydrogen. And then the reverse is true. Alkalosis can develop if we're blowing off too much CO2. If we get rid of too much CO2, too much hydrogen will be taken up by those molecules that would normally bond with that CO2, normal levels of CO2 in the body. Okay, all of this is important, and all of this relates back to gas exchange. pH is directly affected by gas exchange. Also, there's some internal factors within the body that can affect that as well, but gas exchange is one of the big things that affects that. And of course, there's many factors that can affect gas exchange itself. Any of those things that I've talked about that affect the lungs, that affect the pump, or anything like that, it's going to affect gas exchange. Once again, there's some articles on this, and you may not see, don't panic if you don't see some of what I've talked about in your book. Refer back to these slides for some of that information. Feel free to email me with any questions that you may have. Okay?